Welcome to the Be Well Collective, a refreshingly grounded podcast dedicated to separating health fact from fiction, offering listeners access to credible, science-based conversations on a wide array of health topics. Each episode features discussions led by medical professionals and experts, providing listeners with the evidence-based insights to navigate the often confusing world of health and wellness with confidence and clarity. Now let's nourish our minds and get into it.
Today, we will be discussing substance use, abuse, and addiction, and how we can use whole-centered patient care to support recovery. Let's start by defining substance use, abuse, and addiction as outlined by the American Psychological Association and the National Institute of Health. Substance use is a neutral term that describes the act of consuming a substance, such as a medication, alcohol, or an illicit drug. Abuse often refers to using a substance in a way that has negative consequences, such as using it to cope with emotional or psychological problems. Substance addiction is our most severe stage of substance use disorder. This is a chronic, relapsing brain disease, not a moral failing. With continued use, drugs cause long-lasting changes in the brain's reward system, stress and self-control pathways causing cravings, compulsive use, loss of control, tolerance, and withdrawal. Okay, so now that we have those important distinctions in terminology outlined, let's bring in our guest and unpack the following questions as well as research surrounding this topic. When is substance use considered harmful? How can I spot it with maybe a patient, someone I care about, or even myself? What does treatment look like? Does alcoholism ever go away, or is it just something that we're always going to live with? How common is relapse? What myths and misconceptions are there out there? And how does nutrition and mental health play a role in recovery from addiction?
Awesome. We want to welcome Hannah Belcher, who is a fantastic colleague, human, and one of my good friends as well, too. So Hannah B., welcome to the pod. It's nice to have you here.
Thank you. Nice to be here, virtually at least.
Yes, absolutely. Hannah lives in Seward, Alaska, so she's not here with us in Salt Lake City, Utah. But I would love to give just a short introduction on you and then let you take it away. Does that sound good, Hannah?
Sounds good to me.
So Hannah's a registered dietitian. She's originally from the great state of Tennessee, specifically in the Nashville region, and she's always had a passion for serving the underserved. After completing her dietetic internship and master's at the University of Utah, which is in Salt Lake City in the United States, she worked for 3 years at House of Hope, which is a residential and outpatient substance abuse treatment facility for women in Salt Lake City, Utah. And she served as the food service manager and facility's first dietitian, which is a big deal, I just want to say. That doesn't often happen in those spaces. So as a fellow dietitian, that's really exciting. Hannah's also worked to advocate for the role of dietitians in addiction recovery as a presenter at UANS, which is the Utah Nutrition and Dietetics Conference. She did that in 2024, and she teaches guest lectures at the University of Utah on nutrition counseling for substance use disorder. As I said, Hannah is currently in Seward, Alaska, and she works remotely, providing telehealth nutrition counseling to clients struggling with food insecurity. So with that, Hannah, tell us about yourself.
Thank you for the introduction, and I wish I could be there with y'all in the studio. It's a bit of a long commute from Alaska, so
It's true.
had to decline that. I'll just have to vicariously enjoy the sunshine through y'all. But like Sara was saying, my journey as a dietitian, it's definitely been a little unconventional. It's turned out pretty different than what I imagined when I first thought of going into nutrition as a career. I originally wanted to be a sports dietitian since I was an athlete all through high school and college, but I was never a particularly talented athlete, so I was looking for ways to improve my performance and stumbled upon the field of sports nutrition as both something that can help with my athletic career, but also something I could do as a career one day. So originally, I wanted to work with professional athletes, and that's what brought me through my undergrad at Samford University in Birmingham, Alabama, and then on to the University of Utah as part of their sports nutrition concentration. But as I did my internship, I realized a couple things. One, that I like sports better as a hobby, not a job. And two, I wanted to make a difference and was drawn to working with individuals who wouldn't otherwise receive care or who often got put in the margins. I did a lot of work in my undergrad with food insecure populations, feeding them, sharing their stories, and when it came time to look for jobs, I asked myself the question, who is out there that needs help and isn't getting it? And more specifically, who needs my help? Because we all have different stories as individuals, and those stories help shape our gifts and our talents that we can then use to bless the people around us. And part of my story led me to working in addiction recovery, of all places, combined with a desire to not just work in a clinical job in a hospital. And then also, House of Hope was hiring at the exact time I was looking for what I wanted to do. So it was kind of a perfect storm of circumstances. As for how addiction was even on my radar, I grew up with a close family member in and out of an addiction cycle and treatment for alcoholism for most of my teenage and young adult years. So those are pretty formative years in a young person's life. And there's been a lot of growth and healing there. And so when I saw the job opportunity at House of Hope, I saw an opportunity to make a difference for a client population that is often overlooked and misunderstood and undertreated, especially when it comes to nutrition care. I had never heard of a dietitian working in addiction recovery, and so I saw this as an opportunity to build something new that would hopefully make an impact in a needed and personal way. And I've really enjoyed forging new ground, I guess, in terms of a dietetics career that many of us as dietitians aren't even aware of as a possibility.
Thank you so much for speaking to all of that. It's such a important area of the healthcare profession in general, no matter what sector of healthcare you're in, and especially being a dietitian as well. It's not something that's commonly practiced or well publicized that is a career path. So I think that's really encouraging for listeners that maybe are interested in that space, that there's a lot of work to be done there and that can be done. And then on the side of mental health as well too, there's so much that's wrapped up into that. And so we'll get into that later today. We do like to start out our podcast by asking about your snack of choice. Hannah, you're our guest, and guests always go first. What is your favorite snack, or what did you bring today? Either choice is totally valid.
Well, I have a lot of favorite snacks, and it kind of depends on what I'm doing. If I'm skiing in the moment, we go for flat snacks because they don't get smashed if you fall on them, or road trips looks different. But like Sarah mentioned, we've been good friends for a while, and she's been on enough backpacking trips with me to know that I tend to, at least every summer, make some sort of hodgepodge trail mix that lasts me for the summer. And I'm a dietitian, so I get the macronutrients in, but how we get the macronutrients in, that's debatable and changeable every year. So the mix this summer, which I thought was pretty good. It was almonds and pistachios, spiced pumpkin seeds, dried mangoes. I also discovered dried pineapple is a thing this summer. I don't know why I hadn't discovered that yet, but it is, and it's delicious.
Yeah,
And Dot's honey mustard pretzels, obviously.
of course.
Though there's been some weirder players in the mix over the years. This one was actually more of a normal one.
Hannah, I really respect your passion for snacks.
Big fan. Big fan of snacks.
I think that's your best one yet, honestly.
Thank you.
I'm impressed. Wow, I don't know if I can outdo that.
Sarah, what did you bring today as your snack?
I also believe in the art of a balanced snack. So I have a perfect bar, if you've seen those before. They're like the refrigerated protein bar. I needed some protein with my snack, so that's where we're at today. And then I have some snap peas because they're fantastic. They always just hit the spot.
Nice.
I do know that Riley is way more passionate about her snack than probably I am about mine.
Oh, I'm so excited about my
So
snack
I'd love
today.
for Riley to take more of the time here with her snack.
Okay, so I brought a popcorn ball that is wrapped up in wax paper or something of some sort. Growing up, my grandma made these for us every year around Halloween time. So it's something that is very close to my heart. It's essentially popcorn with caramel or some sweet concoction.
Well, that sounds delicious.
Very nostalgic for me, something I had every year. I was actually planning on making it this weekend because my grandma has since passed, but is something that I cherish and love so much about her and her passion of cooking. But was planning on making it this weekend and then went to dinner last night with my mom and my aunt.
Mm-hmm.
And they made cute little baskets for us that
Oh,
included a popcorn ball. So I am so excited.
that is so
Yeah,
sweet.
that is my snack.
Wow. Oh my goodness.
That's awesome.
Okay, now I'm gonna have a bite of it.
I think we should.
I'm glad you took a big bite of that popcorn bowl.
Yes.
Why bring a snack if you're not going to eat
I
it?
know,
I
I
know, it's
know.
true. You got to enjoy it. Thanks for talking us through your snacks. That shouldn't be my favorite part, but I think it is just because it's so fun. However, we are here to talk about substance abuse and addiction, and that is a really challenging topic. It is very layered, it's very personal. It impacts a lot of us in direct and perhaps somewhat indirect ways. And so it's a really important topic to speak to. So I'm really glad that we have this whole team here. I want to jump us into a mini history lesson. I think it's important to set context because we have such a rich history with substances. So, I want to start by talking about the normalization of substances. So, if we think back to early 1900s, we have this normalization of cigarettes. We fast forward to now, it's not as much of a common practice. There's been multiple public health campaigns to push that in the direction of no longer using those substances as primarily or predominantly as it used to be. So we have this normalization, right? Like early 1900s, it peaks in the 1950s, and then we get to roughly like 1964 when you have the Surgeon General that comes out with this report to reverse this trend, and there's this increased awareness of the health risks associating with smoking. And then we have the 1980s, and then us on this podcast would more remember like 1990s, 2000s, where smoking in public places and spaces became less predominant, more restrictions in the workplace and then in restaurants. And then thinking about that with the normalization of drinking culture, that's a whole nother substance. And yet that's really predominant here in the States. And so I think it's so interesting that we also again go back to early 1900s, 1920 to 1933 to be specific. And so that's 13 years where we had Prohibition era. We have the ratification of the 18th Amendment with the goal of reducing alcohol abuse. What that led to, though, as history has unfolded, is consequences that were unintended. So, rise in organized crime, proliferation of establishments that are known as speakeasies, which now we go to for fun and nostalgia, and corruption and significant loss of tax revenue. And that era ended with the ratification of the 21st Amendment, repealing that 18th Amendment. So I always think about the psychological aspects of things, especially because so much of human behavior is wrapped up in our psychology. And so, what this phenomenon really explores is when humans are severely restricted, we have this psychological reactance theory that sometimes kicks in. You see that in modern day, right, with mask mandates. That became a thing that happened as well in more of a modern era. And it suggests that when individuals feel their autonomy is significantly challenged by excessive restrictions, they experience these unpleasant feelings within, right? An urge to resist, an urge to do the opposite, and restore a sense of control or free will. And you layer this part of history with now alcohol consumption is prominent. It is a part of the social fabric of the feeling of belongingness to a group. That's a big consideration for a lot of people. You think about the classic collegiate fraternity space, that comes up quite a
Mm.
bit. Or it's a part of the community construct to gather in the winter season. Winter is a time to be inside, and that often increases activities like substance use because perhaps there's less to do when we have less places to go. And so the point of doing this mini history dive is to show how much there is to substance abuse, how many different substances there are out there that have impacted and shaped our history, and also how that normalization fluctuates and changes with time and makes this topic pretty complex, in my opinion. And so I think when we have normalization, we sometimes forget what it means to cross that threshold when it becomes maladaptive, when it starts to harm and no longer be fun and exciting and enjoyable. And so I think that's a really important place to start is the conversation of when does substance use become problematic? When does it become maladaptive? I'd love to hear both of your thoughts on that.
It's somewhat rare to have a dietitian in substance abuse treatment. I think about addiction and even what is addiction in a broader sense. It's anything that consumes your thoughts and dictates your actions at the expense of your health, your relationships, your ability to function in society. And alcohol, in and of itself, is not a good thing or a bad thing. It just is. Addiction comes from when the alcohol or other drugs of choice become the primary coping mechanism for whatever trauma, stress, or emotion is going on inside. I've had former clients describe it as not being able to get up in the morning or go to sleep at night without having a drink, needing that numbing or stimulating, depending on the drug of choice effect, in order to get through the day. And it usually starts out harmless, having a drink after work to take the edge of the stress off, or even being prescribed opioids by a doctor because of a serious injury. The problem becomes when we can no longer say no to those substances and they begin to interfere with our daily tasks or just normal acts of living. And the drug of choice might start in extreme cases to take the place of food, water, and human interaction, all things that are necessary not only for survival, but optimal living.
Beautifully said.
Thank you.
I think that control is a big piece of when the substance maybe is controlling our life versus when we have control over the substance. Because at first, our drug of choice might be working, right? Like we could be using it to cope with anxiety or whatever
Mhm.
it is.
Yeah.
But it's when it switches and it's taking over, when it becomes maladaptive and it's taking over us and we don't necessarily have control over it. Hannah, is there any indicator for you that someone's maybe like leaning more into abuse and addiction versus just use? Is there anything that you look for or notice?
Definitely frequency of drinks. That's one of the more common ones compared to other substances. How many drinks are we taking in a very short amount of time? And even maybe the binge episode is just a one off. We had a really hard day, or we're out celebrating a birthday or something with friends. And then maybe that's something totally a one off, doesn't ever happen again for that person. That wouldn't necessarily be abuse in my mind. It's when those binge episodes start to become more and more frequent. And like I was saying before, when they start to take the place of other things that you need in the diet or just in life. If I'm doing a dietary recall on a patient, well, what did you eat for breakfast? Oh, I didn't eat breakfast. Did you have anything? Yeah, I had several glasses of whiskey. And I'm like, oh, okay, maybe that's becoming abuse at that point. Let's unpack that a little bit. That was a pretty extreme example, but not unheard of. So that would be the things that I would look for. Aside from like if I'm actually in the office with somebody, there's some physical signs you could look for. A nutrition focused physical exam you can do that's a little more tailored to looking for the signs of malnutrition that often come with alcohol abuse or substance abuse in general.
That's really important because although naming however many drinks we're having is really important, I think that's actually a gap that's sometimes in the healthcare system because we're really, how many drinks are you drinking per day? And it doesn't allow for any flexibility in what may be happening underneath the surface and behavior behind it. And what I mean by that is if someone has more of an issue, we might miss it. And so by what you were speaking to, Hannah, of yes, asking about number of drinks you're taking per day, but also changes in behavior and how it's impacting their health and looking at the whole person versus just like, hey, how many drinks are you having? And when does it become an issue? And not having this very rigid number associated with it
Mhm.
can be really helpful.
That's really important to point out in that it's really more taking that whole patient care approach. What are some of those telltale signs, whether that's physically or how someone's responding or reacting? Riley, that's something you've seen from your experience working in the space that you can talk to.
Yeah, it's hard to say because it obviously varies person by person, but I look and am more interested in like the behavior. What's changing? What are you hiding? What thought patterns are changing for you, as well as how much are you consuming? And that number aspect is really important, but the behavior change and the thought process behind it. And some of those pieces, shame and hiding and isolation and all of that.
Yeah. A really good segue is talking about the nutritional component in all of this. I wanted to bring it back to you because you mentioned NFP, which is a nutrition focused physical exam. Do you mind explaining that? Just because we have listeners that probably have never heard that acronym or engaged in that either as a practitioner or a patient themselves. So, do you mind explaining that and how you would use that in the addiction and recovery space?
Yeah, absolutely. Nutritional focused physical exam is exactly what it sounds like. It's a physical exam, kind of like a doctor would do in an outpatient setting. We're looking specifically for signs of malnutrition, whether that's macro or micronutrient. Often with substance abuse, you have both macro and micronutrient deficiencies. So we're looking for signs of muscle wasting, fat wasting, signs of vitamin and mineral deficiencies, whether that's through dry, brittle hair that's easy to pluck out, whether that's cracked fingernails, ridges in the fingernails, sores around the mouth can be indicators of certain vitamin deficiencies. We assess for hydration, assess for grip strength. Depending on what you're looking for, you can go a little bit more in depth with it. I most often was looking for those general signs of malnutrition, muscle wasting, especially around the temples, clavicles, the fat pads in the cheek region were the primary places I was assessing. And then the vitamin and mineral deficiencies, since these are the things we see most often with substance abuse.
Hannah, I'm really curious since this was such a cornerstone of your practice as a dietitian. Let's say you have a patient and they're experiencing alcoholism. What do you look for and how do you counsel that patient outside of the NFP that we just described?
That's a great question. And alcohol is actually a really interesting one in that if you look at statistics for substance abuse in Utah, also nationwide, and then statistics for admission to treatment centers and what people who are receiving treatment for addiction are there for, what their drugs of choice are. The most common one is not alcohol in treatment centers at House of Hope, but also just in Utah, across the nation. Generally, the most common is methamphetamine, followed by opioids or heroin. Alcohol usually comes after that, but it's a significantly lower percentage in treatment centers, at least, like I said, from the research that I've done on Utah statistics, nationwide statistics, and then also what I was seeing at House of Hope. But also, if you look at the national, not treatment statistics, but just substance abuse stats across the nation, alcohol is the second most common drug of choice for individuals who are abusing substances. So there's that discrepancy between, okay, alcohol is one of the most common drugs of choice that people are using, but relatively few people are seeking treatment for it in substance abuse treatment facilities, which I find fascinating. I think it's in part because alcohol is a legal drug, at least since the repealing of prohibition. It's legal. We can drink. People do so regularly. So there's a lowered perception of danger with it. People don't often see it as a drug, even though it is one, because you can just go out to the grocery store and buy some. So I say all of that to say is first, if I have a client present, especially in more of an outpatient setting, this where I worked in residential treatment, it's a little different because everybody is there for addiction treatment. So let's say we're more in an outpatient setting, the patient may or may not be there for treatment of their addiction. First thing that I want to do is establish whether or not they recognize that they have an abuse problem or that they have even an addiction. Many individuals in their addictions are the last ones to admit that they have a problem because of that shame and that guilt that drives the addiction, like we were talking about. So, a place that I like to start, if a patient admits to regular drinking, though they may deny that it's an addiction, is doing a little digging into anything they wish they could change about their health. I want to find out what their concerns and their priorities are. And often this can open the door to how alcohol may not best be serving them. And then we can have more of a conversation. It's not my job per se to treat their addiction. The only person who can really treat their addiction in a sense is the addict themselves by admitting that they have one and then that they need help to recover from it. And I can help point them in that direction by asking questions like, how is alcohol benefiting you? Are there any ways that it's not benefiting you that you can think of, whether that's related to your physical health or not? And this gets them thinking, and perhaps this helps them view their drinking as the problem that it really is. And from there, I can do more of that typical nutritional assessment, whether that's the physical exam, and also address any complications that have arisen as a result of their alcoholism. Some common ones, we were mentioning the malnutrition. There's often, we see just comorbidities. We know that alcohol, drugs too, they're both highly inflammatory. They just increase your lifetime risk of things like hypertension, high cholesterol, heart disease, diabetes, even any condition that has an inflammatory etiology. Alcohol is generally not going to make it better, or at least, especially alcohol abuse is not going to make it better. Same with drug abuse. So, assessing for those kinds of things. There's also some interesting GI complications when it comes to drug abuse that I'll be looking for and potentially addressing depending on the patient's needs, and some other medical considerations too. So, that was a long winded answer to your question.
No, that was great. It is a comprehensive treatment process, and there is that long-term health impact that occurs with substance use. When you get down the road with it, there are cardiovascular impacts, there are cognitive impacts. There's a range of what we would call metabolic syndrome that can result from usage of different substances. So I appreciate you speaking to that from your standpoint.
Yeah, I wanted to speak a little bit more to like the specificities of some of that malnutrition. Like, we mentioned kind of it in a general sense. Alcoholism, it's interesting too, because we often see direct malnutrition as well as indirect malnutrition. So, direct malnutrition, reduced intake of just essential nutrients, whether that's carbs, fats, protein, vitamins, minerals, anything. Reduced intake due to the alcohol taking the place of food. And then indirect malnutrition is that excessive intake of alcohol or the drug of choice leading to impaired absorption or metabolism of the macro and micronutrients. So, this is just important to keep in mind when doing a diet recall on somebody. As a dietitian, we ask people what they eat regularly. Somebody might be on the surface eating sufficient calories, sufficient carbs, proteins, fats, everything. Maybe they eat. Maybe their addiction hasn't progressed to the point where they have alcohol taking the place of food. But that doesn't mean they're not malnourished. Excessive alcohol intake can inhibit the proper absorption and utilization. Many of your B vitamins, calcium, magnesium, iron, zinc, vitamin A, vitamin D, certain amino acids, just to name a few of them. So, somebody who might be eating what looks like an adequate amount of nutrients, their nutrition status might still be really compromised due to the impaired utilization of those nutrients.
Hannah, I wanted to ask about the major nutritional concerns that you're looking for. And I think you spoke to that a little bit, but I guess I'm just wondering, are there major things that stick out to you when someone's coming in for substance abuse? And do you have a specific protocol that you follow when someone's coming in to get treatment from you?
Yeah, I'll be speaking mostly from the perspective of residential treatment. This could be extended to outpatient treatment, somebody who's not in addiction treatment per se. You can translate a lot of the residential nutrition therapy into the outpatient setting, but it is a little bit different in that when I worked at House of Hope, I had really total control over what went on the menu. So I plan the menus around trying to address all of the complications that come with addiction. Somebody in an outpatient setting, they're the ones that are going to be cooking for themselves. So you got to take that into consideration. Like, what's our ability to cook? What's our ability to meal plan? What does our kitchen space look like? What's our socioeconomic status? All of those things. So that definitely plays a role when we're thinking about the recommendations we make. But for right now, standard protocol in the hospital, specifically for patients with AUD, it includes the banana bag, which is supplementing with some of those vitamins I was talking about, thiamine, multivitamins, electrolytes. There might be further supplementation of key nutrients, omega-3s, zinc, magnesium, selenium, folate. Those are some big ones, depending on the deficiency state. My primary concern when I was in residential treatment was first and foremost to restore what we're missing, to replete nutrition, to reverse some of that malnutrition, depending on where clients were coming from, if they were coming from incarceration, if they were coming from detox. Their nutritional state always looked a little bit different. So the primary goal at first was to restore that nutritional status. I built the menu around providing adequate macro and micronutrients in every meal. Clients ate lunch at treatment. I prepared that for them daily, and then I planned the menus for their breakfast and their dinners, and provided all of the ingredients for that as well as recipes. And the goal was to be meeting their nutrition needs and also make something that's palatable. It does no good to have a menu that a patient doesn't want to follow because either it's too difficult or it doesn't taste good. So definitely had to take that into account. Shows individuals with substance use disorder do often show preference for the sweet taste, as we know, can be an addiction in and of itself. That's likely one of the reasons why people who are recovering from addictions prefer that sweet taste. It activates those same areas in the brain that are activated when one is using one's drug of choice. It's been shown that even sugar can activate it to an even greater degree than something like cocaine or meth or any of the usual drugs of choice. So in treatment, I was mindful of this. I was mindful of added sugar intake for the clients. This was a constant battle between me and the clients how much sugar we were allowed to have in the house for the month. And they didn't necessarily care about the science side of things when we just wanted to make cookies. When we did make cookies, we didn't never have cookies. Cookies are important. But most often trying to opt for those naturally sweet foods and palatable foods like fruit, cinnamon, nut butters, having those regularly available to help scratch that itch for the sweet tooth, but not increase the inflammation that's going on in the body. We already have enough inflammation when it comes to substance abuse. And on top of this, I was also looking for dietary strategies when I was planning the menus to reduce alcohol induced oxidative stress. This can contribute to the pathology of AUD. So, this meant plenty of antioxidant rich fruits, veggies, anti inflammatory spices like ginger or turmeric. And then once we've worked and restored the nutritional status, both macro and micronutrients, we've reduced that oxidative stress. Then I would start looking at functional foods when I was building my menus, foods that contained certain nutrients or phytonutrients that have been associated in the literature with improving cognitive symptoms. There's a lot of promising research out there that's showing benefits from supplementing with certain amino acids, namely tryptophan, phenylalanine, glutamine. And these are precursors to specific neurotransmitters, serotonin, dopamine, glutamate. This can potentially help with reducing alcohol withdrawal symptoms, and in the case of tryptophan, improve symptoms of depression, or at least it's associated with that. We can't say or state causation at this point. So, as a dietitian, I'm looking to add in plenty of those foods into the diet that contain these amino acids and other key nutrients as part of that balanced, nutritionally adequate meal plan. Like I said, we're not at a place yet in the research where we can prescribe a specific diet for depression or anxiety, which does often contribute to someone's addiction cycle. Maybe one day we can hope. But for right now, we do know that certain nutrients are beneficial for reducing symptoms. Things like tryptophan, GABA, selenium, magnesium, choline, omega-3 acids for reducing inflammation, calcium for helping reduce cravings and withdrawal symptoms. And so I aim to include those foods in the meal plan for the clients as much as possible. And then other comorbidities, things like I was mentioning before when I'm thinking about treating the patient, addressing any underlying health condition, especially in residential treatment. Some of my clients would come in and they've had unaddressed diabetes or unaddressed high cholesterol heart disease for years. So trying to not only treat their addiction, but maybe we've had blood sugars up in the 400s for decades, and let's try and learn how to take insulin if we need to, or learn how to count carbs, that kind of thing. And then GI dysfunction, dental issues is something that can get overlooked. A lot of my clients were missing a lot of teeth. So when I was planning the menus or making recommendations, thinking about like, okay, can we actually chew these vegetables? Or is there a way that we need to cook them that we can get them a little bit softer, depending on how many teeth we have left? As well as eating disorders. That was a big one that I saw in my practices.
Mhm.
The co-occurrence of eating disorders with substance abuse, and often the eating disorder being the thing that got somebody into their substance abuse in the first place.
There's a lot that's coexisting at the same time, and we're all human, so we all have comorbidities and we all have other medical conditions most of the time at work as well too. And I'm really curious for you, Hannah, is caffeine usage. Caffeine is a really interesting one because that has addictive qualities. And we know that caffeine in excess can induce greater anxiety for individuals when it's misused. So, with clients that you were working with at the time, how did you handle caffeine? How did you help educate them on that and help them use it properly if they are someone interested in using it.
Yeah, that was one I also, besides the sugar, I got some of the most pushback on from my clients is because they love their coffee. And when somebody's in residential treatment, they're looking for anything that they can have a little bit of control over. Because when you're in residential treatment, especially the initial stages of it, like everything that you have known is pretty much stripped away and you are at the mercy of your treatment team. And that sounds harsh. Like, that's a good thing because your treatment team is there for you, but you've lost a lot of your autonomy. And so, those things that you feel like you should be able to control, namely food, you want to, and you cling on to that. Sugar and caffeine were definitely the biggest ones. And similar to the sugar, for my clients, we were allowed to have 2 cups of coffee in the morning. That was the cutoff. That's a reasonable amount of coffee to get the caffeine to wake you up in the morning, but we're not overdoing it. We're not lighting up those areas in the brain that are activated when it comes to substance abuse. Because we're in treatment. The goal is to not keep reactivating those areas of the brain, at least not excessively. Like we saw with prohibition, if you completely take something away, then that's probably not going to help, at least not help more than it hurts. The craving is still going to be there, or even to a greater degree. So it's not like I was cutting out coffee or sugar entirely. We had it in appropriate and nutritionally adequate amounts, and we didn't go over that. Now, I could explain the science behind that to the clients all day long, and would they care? Not always. Maybe on some level, I used to love doing this in group with them, is explaining like why we were doing what we were doing, whether that was the functional foods with nutrition for mental health. That went over better typically than like, this is why we can't have more coffee in the morning. Because science says that we shouldn't, and they didn't love that. But I was gonna stick to it because we're evidence-based practitioners. That's what we do. We follow the evidence and wanted to have some coffee in the morning, but not go crazy.
Mhm. To be transparent, I work a lot with substance abuse in my practice, but if I do have someone that does come in, I do look for those things. I do look for B vitamin deficiency, antioxidants, magnesium, zinc, calcium, iron, all those kinda talked about. And I think which ties in the mental health component is we focus a lot on omega-3s because we know that those are vital for brain health, mood stabilization, reducing inflammation. Riley, your standpoint with mental health, in terms of therapy modalities, what do you use to support someone that is a substance user or in that addiction space? And what are the main mental health concerns at play here?
Yeah, yeah, yeah. First, I feel so jazzed about talking to you, Hannah, right now because it is so cool. I worked in a substance use facility. It was my clinical year after I was like pretty much finished with my schooling, but they placed us in an internship. So I did that for about a year and then stayed on with them after I graduated and was done with my schooling. I worked at an intensive outpatient facility. So a lot of court mandated clients, primarily men coming in for substance use. But nutrition wasn't something that was often covered, which I just think is so cool. And I was kind of laughing, giggling over here as you were talking about the coffee intake and not trying to replace one addiction for another, because oftentimes that would happen. The guys that I would work with would go crazy on coffee or whatever it was, right? Because they would hyper focus on all of a sudden like working out or whatever it was for them, because I don't think that there was often the nutritional component. They didn't have a Hannah there to talk about the importance of that and how we can jump from one addiction to another. So, very grateful for you and that hopefully that this role and this kind of world of mending mental health and nutrition is expanding. From a mental health perspective, obviously it varies person by person and there's different approaches and the core of it and the basic foundation. The foundation of therapy and the purpose is just to find the why of misuse and the why of your addiction. So whether it's rooted in trauma or maladaptive coping mechanisms, or are people using substances to self-medicate emotional pain, or is there another diagnosis, depression, bipolar disorder, anxiety that are present? And oftentimes I find that just like how you said, eating disorders are commonly seen with substance use, yes, I agree. And it's pretty common if you have a substance use diagnosis, there's likely, I don't want to say always, but there could be something else there. And that's what I've seen time and time again. There's usually other lingering stuff there. As far as treatment goes, the National Association of Addiction Treatment listed out the most common used methods for substance use counseling. So, cognitive behavioral therapy, individual or group therapy, dialectical behavioral therapy, experiential EMDR, maybe like a family treatment approach, motivational interviewing, psychodynamic therapy, relapse prevention, and maybe 12-step facilitation. That'll look more of like AA, traditional 12-step approaches. With all of those different theories splayed out, when someone's coming in for therapy, really they're coming in for an assessment. So they're meeting with a therapist or a mental health practitioner and going over client's history, patterns of use, co-occurring disorders, just that social behavioral context of it all. We're trying to understand level of care that's needed. Are they needing detox? Are they needing hospitalization? Inpatient, outpatient, right? There's a lot that goes into the assessment section. Then translates to, depending on where the person is, whether it's inpatient, outpatient, from a therapeutic lens, is really just understanding the needs of the individual and what recovery will look like for them. So understanding the why, getting them into the proper place, and then building a program that will fit them. Recovery is oftentimes a long-term thing. Doesn't have to be, but oftentimes it is. That is what I would say as far as therapy goes and what it looks like for someone coming in and wanting to seek therapy for substance use.
Yeah, absolutely. That's a really interesting way to kind of broach my next question. When we think about recovery from substance abuse and addiction, there are some people that will say, oh, you'll live with this forever. You'll have this for life. And then there will be other practitioners that'll say it's possible to find recovery. It's possible to be able to reach that spot. I'm curious how you each have found that in your practice. Is it possible to recover?
That's such a hot topic and layered question, I feel.
It really is.
I don't feel like I have a great answer for it because I think my answer to everything is it's layered and it's so dependent on the person.
I agree.
I think it depends on your relationship with the substance or substances. If you're addicted to opiates and then want to use some other substance, alcohol or whatever it is, later on, can you do that? Most research says no, we need to maintain abstinence from substances.
Sure.
And at the same time, I think that there are a lot of people out there that are finding no, they can start using. Maybe they're even an alcoholic prior and then they can drink here and there. I would say most people would say no to that, but I think it's actually more of a conversation that's happening in the world of abstinent versus non-abstinent. And some people are finding that, yeah, it works for them, that they can use substances, but not always. And I'd say the majority say no. Hannah, what are your thoughts on that?
Yeah, that's really interesting. That's more new to me, the idea that you're speaking to them, not total abstinence. I'm going to have to do a little bit more research into that. I can speak from a both a professional and a personal perspective on this. Is recovery possible? I would say yes. I've seen it. I've seen clients go through treatment, follow the steps, trust the process, and then they make it out, and years down the road, they're still doing great, whether that means total abstinence, whether that means maybe for some of them, they are able to have a little bit of the substance, whatever it might be. And they're not in that kind of like we were defining in the beginning, what is use, abuse, and addiction. They're more in just the use. They're not going into the abuse and the addiction side of things. There's also stages of relapse, and that can play a role in this. So I would say it is possible. I've also had clients that they graduated the program and a year later they were back in it. So it's very individual to the person. I think a lot of that comes down to, are they taking the steps necessary to recover and to stay in recovery? Addiction is a disease, and kind of like you wouldn't have somebody who has, let's say, a chronic knee injury and they get PT for it, physical therapy, they do the things that they need to do, things are going great, they're recovered, They can do the activities they were once able to do. Let's say they stopped doing their physical therapy or they let some of those treatments that were working really well slide. The knee pain is probably going to come back. Again, maybe not as severe as it once was, but it could be. Same is true with addiction. It's a disease and should be treated as one. And there are proven treatments that help and help someone recover and stay in recovery. I mean, it has to be a combination of things: therapy, behavior management, nutrition, all of the lifestyle changes. If somebody who's in recovery starts to let go of some of those practices that help them reach recovery, then relapse is pretty likely. If they stop meeting with their sponsor, if they stop going to AA meetings, if they stop having those accountability partners in their spouse, their friends, whoever it might be, if they start letting their sleep habits slide, their nutrition habits slide, if they start isolating from people, there's lots of things that can trigger a relapse.
Yeah. Thanks for speaking to that, Hannah. I think relapse can be a part of recovery. I know I was talking about the abstinent base, and I think I misunderstood that part of the question. It's just very dependent on each individual person. Often means relapse and going through that cycle of treatment again and again.
If I may, real quick, I think there's just more to uncover there. You're talking about kind of different sides and different approaches. And so I think there's spaces for all of it. It just depends on the individual. And I think there are those baseline factors that need to be maintained for relapse to not become a factor. And for me, since I work more in the eating disorder space, and obviously there's overlap with this, it's similar. You have to keep working on those steps. You have to have this maintenance mode always in place. Like you said, Hannah, there's sleep, there's nutrition, there's therapy. And so things do start to go off the deep end when we lose some of those core elements that help us continue to process and continue to do the work. And I think in that, people can find recovery depending on if they keep engaging. But I like the approach from both angles.
I'm really curious, Hannah, your perspective. This is very new to me, working so collaboratively with a dietitian. Do you have any thoughts on what can mental health therapists and dietitians do to work better together?
It's something I would love to see more of in every practice area. I think interprofessional communication is just so important because there's things that you know as a therapist that I have no idea of as a dietitian, and vice versa. So, honestly, the biggest things, especially if we are all on the same treatment team, let's say we're in the same clinic, the same setting, honestly, let's talk to each other first and foremost. Communication is huge. There were many things that my clients at House of Hope were dealing with that I was not equipped to treat, that were more on the mental health side of things, but they were relevant in clients' eating habits. And I maybe wouldn't have enough context to know that, oh, it's their trauma that's triggering this, and this is what's going on because of their past, or this is what they're dealing with when it comes to their anxiety. It was pretty rare and still is pretty rare to have a dietitian in substance abuse treatment facilities. There wasn't a lot of recognition of what dietitians could bring to the table among therapists or among the caseworkers. So just the fact that we're having this conversation now is awesome because that means that we know that both disciplines are helpful in very different ways. And it helps us as practitioners think outside of the box when it comes to our respective disciplines.
Yeah, it's so wonderful because we can learn so much from each other's domain of practice. I can learn so much from you, and there's so much that I would miss if I was just solely focused on someone coming from a mental health perspective.
Yeah, it just makes me think of the value and also how lucky it is when you do get that opportunity to work in a facility, a hospital that has all those disciplines represented. And you get the opportunity to collaborate. Everyone collects bits and pieces of information from the patient, and you have different relationships with your providers. I know there's been some interesting research about the integration of dietitians and mental health therapists together, but just being able to create a unified front really comes into a plan that's both nutritional and psychological based in its goals. And that would be with someone like Riley working with a patient coping with emotional eating, while a dietitian like Hannah or myself are simultaneously providing goals on meal planning or balanced eating patterns, figuring out a structure and a cadence that works for them. And then I know, Hannah, you did a lot of group work in your practice, and I think that is a really valuable space as well too, to co-lead sessions with a therapist and a dietitian present. Being able to pair that education of the dietitian's scientific knowledge with a therapist's ability to bring in that emotional processing and different techniques is really valuable and can take that healing, that recovery, and that shared experience to a whole nother level. The last couple things we want to know from you, Hannah, is dietitians in the substance use and abuse space is not as common. You're the only one I know. From that standpoint, and from your experience, how would you like to see the landscape of medical nutrition therapy? We sometimes call that MNT for short, if anyone ever hears that being thrown around, change to better support substance abuse and addiction care.
So many things. Namely, kind of like Sarah was saying, there just aren't that many dietitians working in addiction. There are more than just me. There are some treatment facilities across the country. They're definitely not the majority, but there are some that do employ dietitians, which I think is awesome. Generally, whether this means MNT for addiction care or just addiction care in general, kind of start from the beginning, like we were mentioning at the beginning, like we just need to talk about it. Addiction thrives when it's left in the shadows. It's one of those things that people tend to feel a lot of shame about, whether you're a family member of a loved one, whether you're someone who's struggling with substance use yourself. Oftentimes we just don't talk about it like we need to, and we don't acknowledge that it is a major public health crisis in our country, and it's one that can be addressed and needs to be addressed by a multidisciplinary team of professionals. That way we can have more effort put into research and developing protocols for effective treatment, whether that's therapy, whether that's nutrition therapy, combination of the two ideally. But substance use disorders, by and large, they're just not talked about as their own entity within the context of medical nutrition therapy. At least they're not talked about that I remember, other than like a little side note when it comes to fatty liver disease and differentiating between non-alcoholic and alcoholic fatty liver disease. But from what I remember, I had 4 semesters of medical nutrition therapy at 2 different universities that had excellent nutrition programs, and I don't remember ever addressing substance use disorder in any of them as its own thing.
Can I interject real quick?
Yeah.
The only training I had was working inpatient during rotations, and you had to do sobriety counseling. And you would walk in and you would hand people a handout that talked about steps to support withdrawal and resources. And that was it. There's very little, at least at the time we were in school and doing our clinical training, and it was focused on alcohol specifically for my training, and it was not focused on other substances. Other opioids and amphetamines weren't even discussed. So sorry to like jump in, but just to put that out there, I think from my standpoint, we could do a lot better in our space, gaining some education and experience. It affects us globally as well too. But I think it's really important to round out education a little bit from a dietary standpoint.
I find it fascinating that for a disease that has so many nutritional implications, like we've talked about this entire podcast, it's something that we don't cover at all as part of our didactic programming, as part of our dietetic internship, unless you get really lucky and there happens to be a dietitian in your area who's willing to take interns. And it's for most of us as dietitians, we're not even aware that this is a practice area that we can work in as a dietitian. There was myself, like Sara was saying, in Salt Lake. I do know of one other dietitian in the Salt Lake area who works in a recovery setting. And there are treatment facilities across the country that do employ dietitians, but they are in the minority. They do tend to be more privately funded institutions rather than nonprofit organizations. And this is despite the research that's shown the effectiveness of medical nutrition therapy in improving outcomes and relapse rates in treatment centers. There is research that shows that effectiveness of medical nutrition therapy, and most treatment centers still continue to not employ a nutrition professional despite the evidence for how beneficial it could be. So I would love to see that discrepancy improve. I obviously think that dietitians need to be part of the treatment team at addiction recovery centers, and that needs to be the norm, not the exception. It's got to start with us as dietitians, people in the profession becoming more aware of that need, whether that's in our schooling or in our internships. and then bringing the value of what we have to offer to doctors, psychiatrists, therapists, social workers, professionals who are already working in addiction recovery. If we as dietitians aren't even aware of the impact of substance use disorder on a patient's nutrition, or if we're not aware of the need for our expertise in treatment programs, then we can't expect other healthcare professionals to be aware of it either.
Mhm. Very well said.
Yeah.
You have a lot of passion, you have a lot of heart for this area.
I enjoy it.
It's really shining through in this podcast, so it's been such a treat.
Yeah. I'm loving this conversation. I feel like it just shows the gap. It's not in a lot of spaces. So I'm really, really encouraged that you're here today and chatting about this and the importance of it. It's really prevalent.
I'm really curious, Hannah, if you had one piece of advice you'd give either an upcoming dietitian that's curious about this in the field, another practitioner, a family member, what would you tell them or what advice would you lend?
Yeah, that is one of my favorite questions because this is something I talked when I mentioned doing guest lectures at the University of Utah to the nutrition counseling class. I've done a couple now, and something that I don't know that we address as much as we should for any topic, but especially something that's as triggering as addiction is inherent bias and your personal triggers. So I always, when I teach those lectures to the students, I like to lead with this because they're going to be in a setting counseling individuals with substance use disorder in an outpatient setting. So it's a little different than where I was. And it's something that I came across really early on in my practice working at an addiction treatment facility that I thought I was prepared for it, but I was not when it got down to it. And it took me by surprise, and I had to really take a step back and do a lot of internal work and growth. Like I said, addiction is a very triggering thing. There may be, for anybody who has experience with it, there might be some unconscious biases and triggers associated with it if you are working with individuals with substance use disorder. So, for example, when I first started working at House of Hope, I, after a while, would find myself on edge or angry, frustrated by things that really shouldn't have bugged me as much as they did. I would have more of a negative attitude toward particular clients, but not really understand why, and just felt like yucky after a while, for lack of a better term. This was probably several months to maybe a year in. I'm a generally really easygoing person. I don't get stressed very easily. I don't get angry very easily. So for this to be continually feeling like this well up of just like more negative emotions, or I was like, what is going on? Something is weird because this is not normal. And when I took some time and did some reflection, I was like, oh, there's behaviors that the clients are participating in. There's things that the clients are saying that's triggering some of my associations from when I was a kid and I was dealing with my family member who was struggling with their addiction and trauma that I had not buried, but maybe just hadn't addressed fully, that was starting to come to light, and things that the clients were doing that I was reacting to and wasn't even realizing it. And so I say that to say when I talk to the students at the U, it's like before you go to work with a population that is struggling with addiction or with substance abuse, do an honest self assessment, like a bias check, trigger check, trying to consider your own background with substance abuse. Maybe you've never been personally affected by it. I would argue that many of us have. It's a hard thing to do, but try to do that self assessment. Where am I at with somebody who is struggling with addiction? How do I view addiction? Do I view it as a disease or do I view it as a person's failure? Whatever that might be. There's a lot of things that get wrapped up into addiction, and it's a hard space to work. And if you want to give a patient the best care that you can, we don't want to ignore those triggers or those biases. They're there. Your feelings are valid and they are personal, and by all means, feel them. But when you go into that space of treating the patient, you need to be able to be the healthcare professional and to leave those biases at the door.
Mhm. Oh, that was so brilliantly said. Yeah, no, you always amaze me, just generally speaking, and that's such an important message. If you're a healthcare worker and provider, whatever you do, it's hard work. You get put in really unique circumstances. You see trauma, you experience trauma. Make sure to reflect, process, but take that time outside of providing care to understand your own bias, trauma, and triggers so that when you do step into that space, you're able to not push it away and never address it, but take care of the patient first and foremost. And then take your time away and go do the work so that you make sure that you show up every day the best version of yourself that you can.
Hannah, it was such a pleasure to have you here with us today. I really want to take the time to say thank you for being with us and to speak to such an important area of healthcare and the overlap between your space and the mental health space. Substance abuse and addiction are never easy, and it's never a linear journey for those involved. I just want to point out, if you have someone in your life struggling with addiction, we hope that this episode provides support and a little bit more context, maybe some ideas on how to best care for that individual or get them in touch with the proper support team. Just a few things to be mindful of. You can manage addiction with collaborative care and a team model. Know your signs, keep lines of communication open, always ask for help, and above all else, you are never alone in this journey. There are dedicated healthcare professionals who are here and committed to this work and the care process. Hannah, thanks again for being here. We really, really appreciate you.
Thanks, Hannah.
Thank you so much for having me. It's been a blast. This is an area, like Sarah said, I love talking about it. I think we need to talk about it more.
I agree.
With that being said, as always, take care and be well.
Be well.
Thanks for listening to the Be Well Collective. If you have any ideas for future episodes or questions, please email bewellpodcast@aruplab.com. If you liked what you heard here, rate and subscribe for more. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. ARUP Laboratory and the Be Well Collective do not assume responsibility or liability for the actions, decisions, choices, or opinions of the individual listener. The content shared should not be used as a substitute for diagnosis, treatment, or medical guidance. Always consult with a qualified healthcare provider before making any changes to your care plan. Listening to this podcast does not create a provider-patient relationship. Use your discretion and take responsibility for your own health decisions. The show is produced by Riley Speth and Sara Hillring. Today's episode was audio engineered by Isaac Acosta Alvarez.